Hello everyone, this is Dr. Sukan Das here. As you know, those of you who have listened to me earlier, I'm a consultant in nephrology and kidney transplantation physician. I have done my MD medicine from King George Medical University in Lucknow. After that, I have completed my DM in nephrology from Sanjay Gandhi Postgraduate Institute, Lucknow. And at present, I am working as the consultant nephrologist in MRI Hospital, Bhubaneswar, where I was instrumental in initiating the renal transplantation program, and my special area of interest has been renal transplantation along with specific areas of intervention nephrology. I'm also the author of A Disrupted World, an Amazon bestseller. If you have been able to go through the book, it is basically an engaging narrative on the impact of COVID-19 and its various endgame scenarios. So today, I'm going to talk about basically something which is core associated with nephrology, or more specifically with renal transplantation. And this topic, which is a very, very interesting topic, very, very important topic, which needs a lot of attention from nephrologists, also young budding students of nephrology, whoever is interested to expand the area of renal transplantation, and this is ABO-incompatible renal transplantation. So what is basically ABO-incompatible renal transplantation? We are all aware that renal transplantation is a procedure, is a life-saving option for a patient of end-stage kidney disease, where, of course, a person with a healthy kidney donates one of his or her kidneys to the recipient who is suffering from end-stage kidney disease. And in this particular instance, it could be a live donor, or it could be, of course, a cadaveric donor. But conventionally, we know that ABO compatibility has been the trend where it is an essential element for kidney transplantation. But over the years, we have tried to overcome this barrier of ABO incompatibility. So that is something we are going to discuss as one of the important points. What is ABO incompatibility? Then why the need of ABO-incompatible transplantation? When we go to explore the need of ABO-incompatible transplantation, there comes what are the challenges for ABO-incompatible transplantation, how ABO-incompatible transplantation has evolved over the years, and what are the various desensitization protocols, and finally, where do we stand as nephrologists all over the world, and especially nephrologists in India, and more specifically nephrologists in places where we have certain limitations in terms of our setup. So it is something we can explore, that each and every nephrologist, even with their limited setups, can explore the ability to do ABO-incompatible transplantation and extend the benefit to their patients. Earlier, whenever there was an organ shortage, we used to resort to paired kidney exchange, and to overcome the ABO barriers, like if a person with A blood group has a B donor, then another person with reverse or vice versa, then they would just work as the A donor from pair 1 gives kidney to the A recipient, and B donor from pair 2 gives kidney to the B recipient in the pair 1. So pair 1 and pair 2 would exchange like that. Similarly, if this kind of things would go on as 3-way exchanges, these kind of things would go on as 4-way exchanges or multiple exchanges, but even this has its own limitations. So there comes the role of ABO-incompatible transplantation. Now, why ABO-incompatible transplantation is not a conventional method? It's not easy, because when you go for ABO-incompatible transplantation without the modalities of what you call as desensitization procedure, then of course the transplanted organ undergoes rapid destruction by reaction, what you call it as a cascade of reactions, by complement activation, inflammation, thrombosis, and ultimately there is endothelial damage, and all these things would lead to a hyperacute rejection. And of course, the hyperacute rejection is a very unwarranted and unexpected situation. I mean, it's not something that we would expect in a routine renal transplantation, and that's something needs to be avoided at all costs. So if we go for ABO-incompatible transplantation without desensitization protocol, then invariably it will result in hyperacute rejection. You know that the great man who had discovered the blood groups and for which he had been awarded with the highest honor that can be conferred on any person, the Nobel Prize in Physiology or Medicine in almost more than 100 years back, was Carl Landsteiner, who has been credited with the discovery of blood groups. Blood groups, you're all very aware that all human beings can be divided into 4 blood groups: blood group A, B, AB, and O. Here, just for your refreshment, just for the sake of repeating here, I would say that why a person of blood group is A, or for that matter B, or for that matter AB, or for that matter O. A person of A blood group has A antigens. And similarly, that same person has got anti-B antibodies. Person B blood group has anti-A antibodies, and person of AB blood group has both A and B antigens, and he has none of the antibodies. That is why persons of AB blood group are also going to work as universal recipients. They can receive a kidney from any of the other 3 blood groups because they do not have any antibodies in their blood. And the person of O blood group has got both the antibodies, but they do not have any antigens. So essentially, a person of O blood group can give a kidney to these people, will basically work as universal donors. You know why universal donors? Because they do not have any antigens. When O blood group is given to someone, they do not induce immunogenic reaction because they do not have any antigens. For the same matter, they have both the antibodies, so they can receive an organ from, or for that matter, blood from another O blood group person. That limits their options of O blood group, and this is the most challenging group who face shortage of organs. Talking about the percentage of the O and the A blood group are the highest number of people out of all entire population. Nearly 45 to 50% of patients have got A blood group, and nearly 40% have got O blood group. The B is the next that comes around 10% of patients. The AB is one of the least common groups with around 5% of people in the population. Then we have this ABO and the extent of immunogenicity. Blood group A consists of A1, which is nearly 80% of people, and A2, which is or non-A1, nearly 20% of people. Now remember one thing: when a person of O has got more immunogenicity against either A or B as compared to a person of A has against B or a person of B has against A. Another factor is the immunogenicity of A1 is more than B to A compared to A2. So A2 people are the least immunogenic people. So there was a point of time, and still there is a point of time, where donor A2 kidneys can generally be successfully transplanted without the preconditioning that is normally required. Because the isoagglutinant of antibody A and B titers of O, this is something I was just telling you. The isoagglutinant titers of O against A and B are more than a person of A has against B, or for that matter, B has against A. That is why the recipients of O have got highest incidence of antibody-mediated rejection. Now, patients on graft tissue transplantation, what is important is that there are 2 kinds of things that normally take place. What is present on the graft tissue? The antigen. And reciprocal antibodies are present in the serum. They can result in ABO-incompatibility and acute graft rejection. Sometimes lymphocytes in the transplanted organ, then the number is limited, can produce antibodies against recipient RBCs and cause immune hemolytic anemia in ABO non-identical organ transplant recipients. Of course, that the second one is something which we are not going to discuss. Our focus would be on core ABO-incompatible transplantation and what are the immunogenicity risks associated and what are the rejection risks associated with it. Minor ABO-incompatibility is hardly an incompatibility. We know that O person can give blood or for that matter, organ to any of the other blood groups, or for that matter, a person of A or B can give an organ to AB blood group. Our concern here is the major ABO incompatibility and how to overcome the barriers to major ABO incompatibility. There have been various attempts and efforts over the years. Ever since renal transplantation started in 1950s, there have been several unsuccessful attempts, especially when a person of A1 or B was transplanted across, when a donor of A1 or B was transplanted across the ABO incompatible barrier, and most of these attempts were unsuccessful, whether it was in 1995, 1955 in Boston, or 1960, 1964. These are all famous names associated with renal transplantation, Murray or Murray, whatever you spell these famous names says. Then Stargell. There's a very famous names associated with the history of transplantation, history of organ transplantation. Even these stalwarts didn't have great results with ABO-incompatible transplantation. However, when A2 ABO-incompatible transplantation used, there was relatively better success in several centers, and 1-year graft survival was 55%. But not necessarily all organs are going to be have, all donors cannot have A2. So we need to develop or look into the strategies which subsequently were developed. Over the years, there has been a lot of research, a lot of experiment, a lot of hard work that has culminated in successful guidelines. The initial people who did the highest amount of work came from Japan. There were several research, because Japan, of course, doesn't encourage cadaveric transplantation so much. They have limited organs, so they put their knowledge, put their energy into exploring various ways of ABO-incompatible transplantation. Thereby, they really succeeded in coming up with various protocols. Several protocols initially used splenectomy and plasmapheresis. Later on in Europe, they did splenectomy. They did without splenectomy, but with rituximab. Subsequently, in the United States, also several protocols came up. So there has been evolution as far as ABO-incompatible transplantation is considered over the years. What are the current strategies that we normally employ for in our setup or in our country, or what are the current strategies that are employed all over the world? One of the first things that we need to do is antibody measurement. What is the existing level of isoagglutinins? If a person has got A, then what is the anti-B antibodies in that person's blood? If a person has got B, recipient has B, and the donor is A, then the measurement is anti-A antibodies. And if the person is of O blood group and the donor is either A or B, then we have to measure what is the respective level of anti-A or anti-B antibody in that person. Subsequently, we have got B cell depletion. After you measure, the next step is B cell depletion. For B cell depletion, we employ strategies like anti-CD20 monoclonal antibody or splenectomy or IVIG, but most commonly these days, anti-CD20 monoclonal antibody is employed. And of course, IVIG in some centers. Splenectomy is gradually getting out of favor. Then third is the antibody depletion. We'll look at these things one after another. Now, removal of circulating antibodies by either plasmapheresis or immunoadsorption is one of the mainstays. And then, of course, IVIG works as immunomodulation, and depletion of B cell population responsible for ABO antibody production through B cell depletion is a very, very important aspect, because subsequently it is a very important step in reducing the further production of antibodies. How do we measure the antibodies? Antibodies are measured by tube technique or gel technique or flow cytometry, but most commonly used techniques are either the tube agglutination method or gel agglutination method. There can be interinstitutional variations as to at what level do we normally accept an organ for transplantation, but at the beginning, the titers can be as high as 1 by 512 or 1 by 1028. So these are very, very important aspects, that 1024, 512 or 1024 or 256. These are very, very important things to understand. What can be the different antibodies, whether There has been a debate as to which antibody, IgG or IgM, which are more important. However, mostly it is seen that it's the reduction in IgM antibody titer which is more associated with a successful ABO-incompatible transplantation as compared to IgG. Okay, so having said that, we will look into the next aspect. What are the strategies we employ for B cell depletion? Intravenous immunoglobulin, splenectomy, and rituximab. The role of IVIG. Where does IVIG actually figure in? IVIG is an immunomodulator. It has an important role in complement down regulation. It also blocks the Fc portion of the antibodies or the Fc receptors of the antibodies. And it also blocks or inhibits T and B cell proliferation, inhibits CD8 lymphocyte cytotoxicity, and it causes increased apoptosis of B cells. So it has got, apart from replacing the lost immunoglobulins after plasmapheresis, it does a lot of great things by further down regulating the activity of the antibodies. Pooled IVIG also contains anti-A, anti-B antibody. This is one disadvantage, that despite all its advantages, it can by itself impart further immunogenicity. And use of IVIG with low anti-A, anti-B titers is very important. It is necessary to prevent hemolysis and antibody-mediated rejection. So it is usually administered after plasmapheresis. I will come to that. Splenectomy, of course, it's gradually falling out of favor, but still it may remain as one of the rescue tools after a refractory antibody-mediated rejection. Now comes to the most popular thing that is employed for B cell depletion, and that is rituximab. It acts as a chemical splenectomy agent. It allows humoral immune system to deal with an intact spleen. And rituximab-free protocols are again coming. Despite we got rid of splenectomy, despite we felt that rituximab is doing better, despite all the advantages, rituximab still has some immunosuppressive effects, and many centers are coming up with rituximab-free protocols. These are many of the centers we have published studies on rituximab-free protocols, and these centers come from Japan, Australia, United States, and Sweden, and they've done successful transplants with rituximab-free protocols as well. Now coming to the most important step. The most important step is, of course, antibody depletion. How do we get rid of the antibodies that are already there? The first thing and the most common thing, which is widely available all over the world, and that is plasmapheresis. A little more specific is double filtration plasmapheresis, and the most specific thing is antigen-specific immunoadsorption. Talking about plasmapheresis, it is the simplest and most common method. It eliminates 20% of anti-ABO antibodies. It has certain disadvantages. It is not sufficiently selective, and it removes volume and it removes a certain volume of plasma. It also removes coagulation factors. Coming to double filtration plasmapheresis, when we use a second filter, double filtration plasmapheresis is capable of eliminating the plasma fraction containing immunoglobulins, and it decreases the amount of plasma discarded. So it's a little better as compared to conventional plasmapheresis. But the most specific is antibody depletion using antigen-specific immunoadsorption. I would like to highlight this specific area here. Using the process of immunoadsorption, a plasma is processed through specific glycosorb ABO immunoadsorbent column, and it is reinfused into the patient. So there is no loss of volume, and thus the number of adsorption cycle has, of course, it has no limit, and also it has got several advantages. Now, what are basically these glycosome columns? These are selective anti-A, anti-B. These are selective anti-A, anti-B columns that contain synthetic terminal triglycerides with A or B blood group antigen linked to Cepheus matrix. So they basically bind specific anti-A or anti-B antibodies because they have got synthetic terminal tricyclide A and B blood group antigens. In addition, sometimes they may reduce immunoglobulins arising out of infection against out of protection against infection from pneumocystitis carinii. So that is why after this procedure, sometimes we need to give a patient prophylaxis with prophylaxis against infection from pneumocystitis carinii. That's a different thing. And so most important thing is that they are very specific in reducing the antibodies that need to be reduced. So what are the different advantages? Once again, I need to specify because these are the columns that have revolutionized the concept of ABO-incompatible transplantation. They give you a chance of avoidance of exposure to blood products that we normally have to endure in albumin, in terms of albumin or plasma when we adopt conventional plasmapheresis. There is preservation of clotting factors. Unlike plasmapheresis, there is no loss of clotting factors here. There is reduced risk of bleeding, and all other immunoglobulins are also preserved, excepting specifically removing anti-A or anti-B antibodies. And it also avoids cost of blood products or any potential side effects related to those. Because of immunoadjuvant, patient plasma is filtered and returned to the patient. It is not discarded as in conventional plasma exchange. So many of the drugs that would have been otherwise removed are also not removed. But the limitation is these immunoadjuvant columns come at a very, very expensive as compared to conventional plasmapheresis. So cost may be a limiting factor. Now coming to, we have understood what agents we employ, then how to employ, when to employ, and what are the timeline of events that we normally adopt, and what is the timeline of events that different centers all over the world use. It considerably varies, but there are certain broad guidelines. In patients who will undergo ABO-incompatible transplantation, normally we use in our center, and of course in some of the centers that closely match our centers, we use a desensitization protocol that begins almost 1 month prior to the scheduled transplant surgery, whether it's 1 month or 4 weeks prior. Some centers start the whole thing almost 2 weeks to 3 weeks before, and it starts with administration of rituximab. The whole thing involves rituximab, plasmapheresis, IVIG, or sometimes in place of plasmapheresis, we use immunoadjuvant as and when the cost factors are not a limiting factor. And transplantation is performed when isoagglutinin titer is less than 1:8. Talking about isoagglutinin titers, of course, this is the target titer, but one must remember the initial titer of isoagglutinins is very, very important, deciding the long-term outcome and how many sessions of plasmapheresis, or for that matter, how effective immunoadjustment would be for that person. The whole thing begins 1 month before. As I said, we need to give rituximab, and rituximab is usually given after pre-medication with acetaminophen, methylprednisolone, and diphenhydramine. Along with that, we also give MMF, or if we want to give mycophenolate sodium and tricoated, then 360 BD or MMF 500 BD. It is started almost 4 weeks before the transplant. This is one of the important areas to remember. And we need to give some sort of antimicrobial prophylaxis, as I had mentioned earlier, with dimethoprim sulfamethoxazole for protection against pneumocystitis carinii. Then we also have to give acyclovir. That is also another important area here. Now, the other thing is important. What do we do after that? At 2 weeks prior to transplant surgery, we obtain isoagglutinin titer and a final cross-match. Based on the isoagglutinin titer, we plan a pre-transplant plasmapheresis to achieve it, to reduce it less than 1:8. And sometimes when the titers are very low, then of course plasmapheresis and all those things may not be necessary, but that's something, if that had been the case, then we would not be looking at all these things. We need to look at the challenging areas. And also, what is the number of plasmapheresis stations then one needs to go for? As an example, this is a very interesting line here. This can be used in estimate to the number of plasmapheresis stations. As an example, if the starting titer is 1/64, it will take 3 plasmapheresis sessions to achieve to 1:8. Sometimes, whenever you have a have a titer of 1/64, then remember there are certain variations. It may not be exactly 1/64. It could be 1/128 or 1/32. So one less or one more. So you have to plan accordingly. Then admission of patients. Patients are usually admitted 3 to 4 days prior to the scheduled transplantation surgery. Sometimes you may do it 1 week prior to the surgery. You do other lab parameters as it is necessary, and you do daily plasmapheresis, almost 1.5 volume exchanges with 5% albumin replacement with each plasmapheresis session. And sometimes, if this is a very important thing, if at all you need to give FFP, then it has to be ABO type AB male to prevent infusion of anti-donor antibodies, or if that is not available, donor specific plasma should be used. So the plasma that is used in an ABO-incompatible transplantation should be AB male type plasma. And of course, as these are some of the things, how we use IVIG and what are the advantages of it. Induction and maintenance immunosuppression, it's not significantly different, but commonly you would like to use ATG as induction agent. Some centers also use, as centers are trying to be less and less aggressive in immunosuppression, they might go for basiliximab as well. And maintenance immunosuppression is absolutely same as compared to ABO-compatible transplantation. However, I mean, we use the same triple drug regimen as mycophenolate, tacrolimus, and prednisolone. But here we desire a higher tacrolimus level as compared to ABO-compatible transplantation. The higher tacrolimus level in ABO-incompatible cases as compared to ABO-compatible scenario. Now, how do we monitor after transplantation? Again, all patients, whether compatible or incompatible, will need some kind of monitoring after transplantation. But following ABO desensitization, there are certain important areas. Here we monitor isoagglutinin titers almost every day as long as the patient is there in the KTO or the kidney transplantation unit. After that, 2 to 3 times a week for every week for the first month after the transplant, then weekly for 2 to 3 months post-transplantation. Then, of course, it depends. Some centers do it once or twice in a quarter, and after that, of course, you do it every 6 to 8 months or maybe yearly, and as and when the need arises. Some centers would suggest that if the titer is more than 1:16, a kidney biopsy or preemptive plasmapheresis is performed. And but I think every center, every clinician would use their own judgment, not just the titer. The various other parameters along with renal parameters should be taken into consideration. The good thing about ABO-incompatible transplantation in the long run is, of course, hyperacute rejection does not arise within the first 2 days. Does not arise if hyperacute rejection doesn't arise within the first 2 days after transplantation, then the chances are very less that will happen. Any kind of rejection would happen. The chances are good for the patient as far as the acceptability of organ is concerned. But acute antibody-mediated rejection occur especially within 2 to 7 days post-transplantation. These 2 to 7 days are considered as critical period. However, after that, something very interesting happens here, and that is known as accommodation. Once accommodation has been established, there are no further instances of acute AMR due to ABO-incompatibility, and this continues for the life of the graft. This period is termed as the stable period in the transplantation phase of the patient. Now, why accommodation is so important and how does it differ from tolerance? These are the 2 terms you must have come across as whenever we talk about kidney transplantation. Accommodation is a situation where unresponsive allograft to the immune system, the allograft becomes unresponsive to an active immune system. Tolerance, of course, is the unresponsive immune system to the allograft. So accommodation is defined as a phenomenon whereby graft rejection is avoided despite re-emergence of an incompatible antibody. In 2006, American Society of Transplantation reached a consensus on accommodation, and it occurred when they noticed there were, even after C4D deposition was detected with normal function and structure of the graft, there was no amount of rejection noticed in these patients. So accommodation mechanism, why it happens? Shift from immunoglobulin G isotype to IgG2 isotype that is less effective at activating complement. Decrease in tumor necrosis factor alpha and alteration in SMAD gene expression may be important in long-term accommodation of grafts. Upregulation of a CD59 accommodation by preventing formation of MAC on accommodation of the graft. So over the years, ABO-incompatible transplantations have been doing well. Patients are having comparable outcomes as compared to compatible transplantations. So this is a very welcome scenario. Graft survival is great. Patients are doing well, and we are having great results for these patients. So I think ABO-incompatible transplantation is no longer a barrier, no longer a limitation. We can extend this benefit to so many people with the tools that are available to us. All that we need is to incorporate the knowledge as it is evolving and keep learning as newer and newer things keep coming, and keep sharing knowledge from each other, from one center of the world to different centers. With that, I conclude my presentation. Thank you very much. Thank you very much once again.